right, we're going to go ahead and get started. Thank you to everyone for coming to this afternoon. I know that there's a lot going on, so I appreciate everybody here. And I really appreciate the opportunity to do this symposium. I've been really excited about this. I wanted to give a little bit of background about how this really developed. Many of you heard Bob Heinzen talk earlier in the program about the rollout of RAISE and the development of first episode psychosis services in the US. We were talking about what might be interesting and what might be really helpful at this conference and that integrated some of our experience. What we're really going to be talking about is what's happened since then. What does it look like when we're rolling out this these first episode programs in real world USA? And what are the strategies that we've taken to improve dissemination, to improve training, and what are the challenges that we faced? And so you'll hear from 3 different programs. The first one is going to be Aruma Bello, who's going to talk about RAISE Connections, and that was originally based in New York and Maryland, but she'll talk about now that they're also in many different places. And then you'll hear from Katie Hayden-Lewis, who's going to talk about EASA, which has been primarily in Oregon, but they're also starting out and doing some training in other places. And then you'll hear from Susan Gingrich, who's going to talk about Navigate, and we'll talk about our experience in disseminating Navigate across the US. And then you're going to hear from several experts across several different countries who are going to respond to how it is similar to or different from their experience in rolling out the first episode programs and whether the challenges are similar or different from. So, without any further ado, I'm going to introduce Aruma Bello, who's going to talk about RAISE Connections.
Hi, everyone. It's really great to be part of this symposium, so I want to thank Piper for inviting me to present. And we're going to talk today, thank you. We're going to talk today about coordinated specialty care for On-Track New York. So RAISE Connections was the research project for the RAISE project, and it turned into On-Track New York. There were a little bit of adjustments to the model. So now the dissemination is really based on the On-Track New York model that I'm going to be describing for you today. So I'm going to start with an overview of the on-track model and its components. Then I'm going to go into how we're disseminating this model across the US and in New York, particularly, and I'll talk about the different ways we do it. What's the training approach, as well as what are some of the challenges that we faced. So this is how we market On-Track New York, and I wanted to put this up here because there was a lot of thought that went into how do we, once we shifted from a research project to now something that is widely implemented, how do we think about this and how do we encourage young people and referral sources to connect with us? So there was a lot of thought that went into this and a lot of expertise. And the notion was to present it in a way where we're really addressing young people and what's important to them. So related to goals for school, for work, and relationships more so than addressing psychosis or symptoms, etc. So part of what we do with our teams is to help them think through how are you going to convey the message of what it is that you're doing, of what your program is about. So inclusion for On-Track New York, particularly, it's non-affective psychosis, schizophrenia spectrum type disorders, ages 16 to 30, and individuals must have psychosis for at least a week and less than 2 years. And that's to say, let me just go back to this slide a second, that is also to say that although we have this criteria, not everyone, as we've disseminated beyond New York, not everyone is adhering to this criteria. And people are choosing different criteria. So I just want to put this out there that although we have our criteria, not everyone that we're working with is working with the same exact population. So how do we think of our model and what do we include in our model right now? So we try to think of it as a suite of evidence-based practices to a certain extent. So there's evidence-based pharmacological treatment, supported employment and education based on the IPS model, recovery skills. What do we mean by recovery skills? CBT-based interventions, treatment for substance use, trauma-informed care, things like that. Psychotherapy and support, so that's where the case management piece really comes in. Family support and psychoeducation, suicide prevention, all under an umbrella of shared decision-making, a lot of assertive outreach and engagement. And now, more recently, we've added a peer support within the model, which means that our teams are now in the process of hiring a peer that's going to be delivering services as part of the on-track team. And all of that obviously is with a focus on recovery. And the team is encompassed by 4.0 FTE, so full-time efforts. And I'll give you the breakdown. So we have a team, and this is one of our teams. This is one of our original teams. This was the prescriber on the team, the nurse, the outreach person, primary clinicians, and team leader. So how do we think about a team? And this is where On Track gets a little bit confusing, I think, when you just kind of pick up our manuals and try to think of how are you going to put your team together. We really try to help during the dissemination process for agencies to think through how are they going to do this? Who are the players? We do it by roles. So we say there's a team leader role, an outreach and recruitment coordinator role, and a primary clinician role. And those 3 roles are 2 full-time efforts. Usually the team leader is a full-time person. The rest of the roles could be part-time people, or it could be 2 full-time people doing all of this. But the idea of using roles is that there is a focus on these specific components of the model. So there's someone that's leading the team who may also have a caseload, but then there's also someone that has a specific kind of focus on outreach and recruitment. How are we going to detect cases? How are we going to evaluate these cases? How are we going to get the word out to the community about our program? And then we have the primary clinician role, which in our mind is someone who kind of oversees the case. They do the case management and the therapy piece. Then we have a supported employment and education specialist full-time, so that's all they do. We have a prescriber for 0.3% of the time, a nurse 0.2% to help, and then the peer specialist will be half-time. So that's how most of our teams are comprised, especially the full fidelity teams. So what are these roles about? What do the roles encompass? The team leader role, the hat of a team leader, is really to ensure administrative and clinical supervision to team members, and it's the person who serves as the liaison between the host agency, so the bigger agency where the program is embedded, and the program. Then outreach and recruitment specialist, this individual really works to inform community providers, inform them about the treatment model, about what's different about early intervention services compared to what's already out there. And then they're really the ones that perform the eligibility evaluations. Our team leaders, outreach, recruitment specialists, and primary clinicians are licensed and at least master's level individuals. So we really think that we use these individuals to do the evaluations rather than the prescribers. So they're the ones that determine whether somebody can come into the program or not. Then we have the prescriber who really works with clients on medications, using shared decision-making. The nurse whose primary responsibility, we realized from a difference from RAISE Connection to On Track was there wasn't enough prescriber time. So part of the thought was if we have a nurse, they can help with the wellness piece. We know all the side effects of antipsychotic medications. So paying attention to diet and exercise is something that could be done alongside the nurse in the prescriber role. Then we have the supported employment and education specialist who takes the lead in assisting the client with educational goals and the IPS model for supported employment. And then finally, the peer specialist. And this is still a little bit vague because we're just developing this. Most of our teams are in the hiring phase right now. And we're really, we tried to look for models for this, and we couldn't find anything very specific for FEP that would directly inform stepwise what we should be doing. So instead, we are trying to learn as we go. So we developed a draft manual for this role, and then as people hire and the peer specialists do the role, then we're hoping to get feedback and understand what works, what doesn't work. But in general, we're thinking that it'll promote engagement, it'll promote the notion of recovery, and it'll help people bring in the lived experience piece, which we know is so important for this work, but has kind of been missing as part of the model. People were getting it adjunctively before this. So we think that it's very collaborative, and what's really important that we always advocate for On Track is that it's the team approach. That's kind of what makes it really effective. So the notion is that we have these sort of concepts, clinical concepts that drive the model, like shared decision-making, recovery, culture, and then we have these interventions, right? Like specific case management or family psycho-ed, all around individual preferences and needs. And then we have the team, and the team is comprised of the roles, but also like the young young person and the family, so that everybody's coming to the table together. It's a seamless approach. Everyone has access to everyone, and as they're working with the cases, everyone knows what's going on within the team around decisions that are being made. So now I'm going to talk about the dissemination. So we started after Raise Connection, or I think it overlapped a little bit with Raise Connection. They started with 4 programs in New York City. They looked for population density, and that's how they decided which programs we're going to start off with. So the first 4 programs were in Westchester, in Manhattan, in Brooklyn, and in Long Island. And then from there, we expanded a couple years later with the set-aside and New York's commitment to the dissemination of this service to 8 programs. And they wanted to then start tackling the rest of the state, because the population in Manhattan or New York City is very different from upstate New York, where you have different socioeconomic statuses, more rural, the needs are different. So we wanted to make sure that everyone in the state was getting the services. But once again, if you notice, the locations were selected based on still population density sites, so that at least they could generate referrals. And then now in New York, we're upscaling up to 20 programs with the new increased set-aside funding. So right now we have, I think, 17 that are already, and 2 more that are up and coming, 3 more that are up and coming. In addition to that, then we started working with OnTrack USA. I think a lot of us here today, what ended up happening is that as the set-aside money came out, a lot of the different states that wanted to starting these services for their young people started reaching out and developing technical assistance contracts. So for OnTrack New York, we've contracted now with 14 states. We work with maybe 32 teams. And then we also work with Puerto Rico and the Pacific jurisdictions. So depending on the amount of the set-aside that they got, we went out, we did technical assistance, and the contracts vary. So in New York, we have a very specific training and implementation plan. In USA, it depends. It depends a little bit on the contract and how much funding they have and what they could do with that funding. So that's why I say the criteria might be different, the objectives might be a little bit different as these programs get disseminated. So how do we train? We start with pre-implementation. So even before, as states get these money, they'll reach out to us, and our director, Lisa Dixon, will start working with them, thinking through what are the elements, what is needed, how do you even embed a program within your host agency, kind of doing that crosswalk between the elements of the model and what it's going to be required and the staffing with what are the local resources and what are the expectations for identification of populations that might need this. Also mapping existing policies and procedures. And that's been a little bit of a challenge that I'll talk about at the end of this. There's also addressing the child and cross services divide that we talk about. Because we go from 16 to 30 in a lot of these clinics, the adult services and the child services do not intermingle. And so it's figuring out how do you develop a program that now bridges a population that goes from 16 to 30. When before, the way that clinic, or whether it's a community mental health clinic or a hospital, really thinks about it more siloed. So part of what we come in and start talking to people about is how are you going to integrate both of these things? And then staff hiring. A lot of these programs, they're bringing in staff from the outside. So what staff, what should be their qualifications? As we have like job descriptions that we give to programs. We have our manuals details, so what are the skills that people should come in with, or level of education, et cetera. Then once people say, okay, we're gonna do this, we have our team put together, then we start with our training. And this model of training, like I said, it's very robust for New York. And I'm gonna go off of the New York model because that's what we do more of. And it will change depending on what people want for other states. So for example, we always start with a 3-day kickoff training. So we go on site for 3 days and deliver 3-day-long presentations on the background, the research, where it came from, the clinical concepts, And then we go day 2 and 3 into each role. What does each role do? And ideally, we have the people in the room that are going to be performing that role. So we start building that rapport and that relationship with those individuals, but also letting them know the lay of the land. This is what you're going to have to cover. These are the kinds of responsibilities and duties that you're going to have under this role. A lot of times when we do this piece, teams haven't thought this through, or they haven't read the manuals, so we're really starting from scratch to get people to start understanding that you're not, for example, as a primary clinician, you're not just going to be a typical therapist with 15-minute sessions in your caseload. You're going to do a lot more, and you're going to have to work in this team approach and do all these other things. Then we have a very robust learning management system. So we work for the Center for Practice Innovations, which is part of the Columbia University and Psychiatric Institute in New York. And we have these for a lot of the different initiatives, and On Track is one of the initiatives. And in this learning management system, we have webinars that people can do self-paced learning. We have all of our manuals. We have resources, literature that people can access. We have demonstration videos of different pieces of the intervention that people can go in there and learn about. We have recovery videos, shared decision-making videos that our teams can use with the families and with the young people, so they're not having to reinvent any wheels. So, and then just a lot of tools, handouts and tools that different collaborators have developed. We work a lot with Pat Deegan, who is in the US very famous for doing a lot of shared decision-making work and recovery-oriented work. So Pat works with us doing consultation and also developing tools and videos and things like that. So what we're trying to do is not only, through the learning management system, not only educate our teams on what's out there, but also give them the materials that go above and beyond just the manuals. So that's how the learning management system works, and everybody has access to that. Then we have different types of calls. So we're always on the phone with these teams. We have care review calls where we have entire teams join these calls. It's usually 2 teams, and we discuss a case in depth. And this happens once a month. And then we have a group of trainers. So we'll have, usually it's Pat and 2 other trainers that will provide feedback on the case, recommendations, and the other team will also provide feedback based on what they've experienced. So it becomes like this learning collaborative. Then we have calls at different schedules and different intensities for individual roles. Then we have core topic webinars. So if people say, I really am curious about PTSD, then we will have a specialized webinar call on PTSD and first episode. So depending on what people need, then we will address that through phone calls and webinars. And then we do administrative consultation. So we'll talk to if there's issues with the leadership, we'll go in that direction and try to sort those things out. So now quickly, let me just go through some of the challenges that we've experienced. And these are not all the challenges, these are the main ones that we've noticed. A lot of times where our teams are struggling, especially in the beginning, I think it gets better after about a year, is this idea of who's eligible. Particularly in New York, where we're keeping it to non-affective psychosis. When we spread out to the US, a lot of US sites are accepting affective psychosis, so that diagnostic clarification is not as necessary. At the same time, we're seeing a lot of complications when they accept those caseloads because we feel that our model really falls short. I know when I'm on those calls, I'm drawing from other things a lot of times. I'm not drawing from just the on-track model. So we're really spending a lot of time and enhanced resources to train our clinicians in On-Track New York on how to determine eligibility appropriately, short of using a skid on everyone, which isn't realistic, which is what they did for the research project. So a lot of it has to do with talking about the comorbidities and doing timelines and teaching people how to do timelines and ask questions in a way that doesn't just ask, a list of DSM criteria. Another challenge has been that not everybody has a basic recovery foundation. A lot of folks have this general medical hierarchical model, and the larger agency kind of has that formulation of how to work with people, and our model is very different from that. So it's getting people to shift their framework real time to work with these individuals in a different way, to be more open, to not close cases too readily, to engage people in ways that are more effective. The other piece is shared decision-making. We talk a lot about shared decision-making. We give people operational steps for doing shared decision-making, and yet what we notice is that this idea of tolerating risk, which is what shared decision-making does within a team, it allows you to give people an opportunity to try more things out, is really hard. and our teams still become very overprotective. So there's a lot of these non-specific things that you're trying to train people to let things go, see what happens, feel more comfortable, rather than feeling like you have to dictate what people should do. And then the guidance for supported education, particularly in New York, where the school system is very complicated and there's like 3 high schools within one setting and it's not all by catchment area, it gets very confusing, and there's been a very steep learning curve for our supported employment education specialists on how to do this appropriately. And we've learned way more from our Cs than what we could provide, so we're actually making edits to our manual. The other piece is obviously what we're all struggling with, I think, in the US, is the financial sustainability piece. We have these great models. Right now we have protected funding to do them, but how do they get sustained? How do they stay? How do they not go away once a set-aside goes away? Because a lot of the things that we do aren't billable. So this assertive outreach and engagement and connecting with people for weeks before they even get admitted into a program and billing can start, that we know is what engages people into our program and allows them to stay and helps with retention, none of that is billable. And that's a lot of hours that our clinicians spend doing that. Even some of the outreach and engagement activities, although we don't think that we're similar to an ACT model where you do everything in the community, especially in the beginning, you're doing a lot of things in the community to engage folks, and not all of it might be billable. Our model really says that the individuals should have 24/7 access to our teams to prevent crisis, to prevent hospitalizations, because our clinicians have that relationship and they can help people think through things without feeling like you're going to send them to the hospital. And yet, because of certain clinics in New York and union rules and things like that, they're like, we need to use other services for that. And that's been, within our New York teams, that's been a barrier of how do we think through that process, and how do we help teams do this effectively and build maybe connections with crisis services to, I don't know, make it more feasible when that's not really how we think about delivering the services. So those are the main challenges. So in conclusion, we know that CSE services are being implemented. We continue to expand. We're expanding rapidly, which is great, but it's also humbling because there's a lot of gaps. We hope that the scientific evidence and as we learn more of the local experience, our model will continue to evolve. It's not static. There's been a lot of changes, even in these couple of years that we've been expanding, and there continue to be changes. Our training approach really has had to adapt to gaps in people's knowledge and thinking. We started with a very pristine early intervention community, and now as we expand further, people are not even aware of what this is about. So we've had to address that in training. And then the financial piece, although it's a hurdle, we're working closely with our Office of Mental Health in New York, at least, to help figure out like a one payment system, at least for people getting services in New York. So, and that's it. Thank you so much.
All right, and now I'm going to introduce Katie Hayden-Lewis from EASA, who's going to talk about her experience.
Thanks. It's pretty great to be here and learning from everybody, and I'm incredibly honored to be part of this group, but also incredibly honored to be part of representing the EASA Center for Excellence based in Portland, Oregon. I work with an incredible group of people and a network across the state that's really behind the guidelines in our program efforts. And I've been doing that for about 10 years, and it's just astonishing to me, the growth, very exciting. So here we go. Let's see. There we go. So EASA was the first statewide dissemination in the United States. That's pretty exciting. So we started out building the plane as we were flying it, which we still continue to kind of use that analogy of the experience. So very dynamic process. So EASA began 1997, Medicaid healthcare reform, developed the Oregon Health Plan, which is Oregon's version of the Medicaid services. Created regional managed care entities, which really started to focus on prevention and evidence-based practice. In 2001, an organization called the Mid-Valley Behavioral Care Network implemented early psychosis intervention in 5 counties. And that was, I want to mention Tamara Sale, whose name was originally in my spot. She was the first person to really get the program going in Oregon and was an advocate and very passionate about doing this work and disseminating it in Oregon. So that program was tremendously successful. It involved both clinical practice success, improvement in outcomes, reduced length of stay in hospitalizations, reduced interactions with law enforcement, and it also started to generate a real grassroots movement of people, family members, and individuals with lived experience. And together, they were so successful in approaching that they approached our state legislature in 2007 and they had the data to say, we've been so successful with these outcomes, and they heard from people with lived experience, which was very compelling, rather than just the clinical providers saying we want more money. We had people coming forward, approaching the legislature saying, will you give us the opportunity to roll these programs out? And I believe it was 6 other counties were able to come forward. One of the key pieces in the early dissemination was that the originators, Tamara Sale, and I think Ryan Melton was probably there, they're my colleagues at the Center for Excellence, developed a plan where in order to access the funding, the people at the highest level of the healthcare organizations had to come forward and I believe sign a contract that said they would do whatever they needed to lift the barriers to the success of early intervention services. So the power structure was really flipped. Rather than clinicians pushing up against the ceiling saying we need this, there was an agreement that said we want people with the highest level of authority and power to help us because they're in a position to open doors. Pretty incredible. That's when I came on board. So I feel very fortunate, very powerful. So Oregon's model originated with Australia's early psychosis prevention and intervention program. I think it was mentioned earlier on, a couple days ago maybe, that Tamara kind of brought it over to Oregon, and we started to adopt and develop a modified version of the Australian national guidelines. The guidelines started to change based on feedback processes and reflecting new and emergent evidence-based practices, as well as feedback from the clinicians, individuals, and families that were really partaking in the daily clinical work. And also reflecting kind of strategizing and problem solving around implementation barriers and concerns. This continues to be the practice with our fidelity guidelines, which I'll talk about in a bit. So they're really a living process based in evidence-based practices, but reflect the lived experience of consuming or participating in those practices. We have a public health model, so services have to be available regardless of insurance status, privately insured, no insurance, Oregon Health Plan. It's based on clinical criteria. It is not based on socioeconomic status or decisions about whether or not to have health insurance. This is our website, so if you want to learn more, it's full of resources. It's one of our one of our core teaching tools. So that's on there. Who we serve. The EASA programs serve schizophreniform psychosis, bipolar spectrum psychosis, clinical high risk, typically ages 15 to 25. However, local sites, in Oregon we have counties, so there is those specific regions. They are permitted to make decisions around age, and this should actually, some sites serve as young as 12, and some sites go up to 27 or 30. The older age, one of the arguments was onset of psychosis, as we know, can start a little bit older, and certainly there's some evidence that people of female biological gender might have onset of psychosis a little bit later, and we did not want to exclude those cases, and again, all insurers. EASA has fidelity guidelines. They focus on, some of these are probably common understood as evidence-based practices. So we understand that community education is incredibly important. So that means educating anybody that might know a young person. And it's actually a core practice. It isn't a secondary practice, which is different than most, as far as people that have clinical training aren't typically trained to be community outreach educators, similar to public health service models. And that's expected because we know that in order to identify and reduce duration of untreated psychosis, community education is imperative, as well as combating stigma that can also increase DUP got to have community education. It's a big piece. Rapid access and proactive engagement. We have an expectation that anyone that calls, first of all, anyone can refer to an EASA program, and that anyone that calls gets a return phone call from an EASA team member within 24, no more than 48 hours saying, hello, we want to talk to you, we got your call. IPS model, very similar. We've been successful with partnering in Oregon around allowing and promoting our supported employment specialists to also provide supported education, since we know on the developmental spectrum, young people are looking at job, career, school, where they all fit in, so it fits. Evidence-based multifamily psychoeducation, Bill McFarland's work and Carolyn Anderson's work have been instrumental. This is a core practice, multifamily groups. Assertive community treatment level of care, so high level of case management, meeting in the community. Clinical case management, integrating CBT, MI, and substance use treatment. Individual psychoeducation that also, again, reflects typical developmental frameworks and culturally informed explanatory models. So we really want to get at where people are at, what matters most to them, integrate that with our clinical understanding of what often helps, and make sure that it's congruent with who they are and who their family sees themselves to be. We have occupational therapists that focus on activities of daily living, psychiatry, nursing, and are beginning to integrate more formally peer support. The teams work on a transdisciplinary model that are strengths-based. Transdisciplinary means that we have team members that take the lead in their area in which they're trained in and their scope of practice, but routinely crossover function. So if I'm trained as a mental health counselor and I'm talking with somebody and what they really want to talk about is school or work, I'm not going to say, why don't I get you connected up with that person? I'm going to feel comfortable and be trained enough to continue that dialogue and then do a warm handoff to my colleague around those needs and goals. Services are individualized based on the person and support system's needs and goals. We know that those change over time, both because of the transitional nature of symptoms, whether they are improving or not, or things are getting worse, as well as the transitional nature of this time of life. Needs and goals change. That's pretty normal, so we want to follow that along. Something that's very cool, I think, about what we're doing in Oregon is we also have reciprocity in the state. So if you enter one EASA program, let's say in an urban area in one region, and you're 19 years old, I'm thinking, and I'm going to college, and we've got a 2-year program, and I'm a year into my EASA program, I can leave one community and go to another community, and they pick up my services. So that's very exciting. So again, we follow the young people where they go, rather than asking them to follow us. We have a fidelity review process based on our fidelity guidelines. The fidelity reviews happen every 2 years. The state funding allows universal access and covers non-billable services. We at the Center for Excellence coordinate ongoing training and consultation. All staff are required to complete core training. That's an introduction to EASA, that's the multifamily group training, and the differential diagnosis training. We want the teams to have shared understanding and knowledge so that they can be engaging with people from a similar approach and similar understanding. And the programs generally are about 2 years. Sometimes we have alumni that stay on, particularly to access support and employment and education, and or to access multifamily group. The EASA guidelines have developed over time. So we originally developed the fidelity tool in 2004 based on the Australia guidelines. It's been updated 3 times, 2006, 2008, 2012. We're moving into another phase of updating the guidelines. So again, they're lived, they're what's working in the field, give us that feedback, what's happening in evidence-based practice, putting it together and updating the guidelines. We also, in 2008, we added the systemic infrastructure, that's a lot of S's, to the practices, as well as in 2012, we added participatory decision-making section, and we added transition planning sections. So we focus on transition from day one, sending a message that this is a snapshot in time, and life and your treatment and support will change, and we want to support people to not need this level of intensive services. We also added language around cultural considerations, which are throughout our fidelity guidelines, so we offer training in cultural humility, cultural adaptations. Implementation and dissemination efforts. So it's pretty exciting to say that over 90% of our population in Oregon has an early psychosis team, which is really exciting. A lot of work went in for a lot of people being willing to try this out. Remaining dissemination efforts are focused on rural and frontier communities. This year, the Center for Excellence developed the Rural Services Director position. That's the role I take. My focus is on adaptations and implementation in rural and frontier communities based on resource, culture, and need. So, national dissemination, what are we doing? We've provided direct technical assistance or training to programs in 17 states. We facilitate national learning collaboratives, including participants from 12 states. Our trainings are open to anyone in the country that want to attend in general. We've got a pretty open door policy. We provide ongoing consultation and support to national audiences through webinars. We have a webinar, one of the only webinars that focuses on differential diagnosis. I believe it's out there, it's very exciting. We're taking the lead in 2 states to help them decide how they want their early psychosis services to look. That's in Kentucky and Alabama. Tamara Sale co-chairs the National Training and Technical Assistance Work Group. We don't view all the work as needing to be a replication of EASA. We really want to integrate and encourage the adaptation and adoption of RAISE processes and let local communities and states own their work and make decisions about their work and what it needs to look like to be effective. We've participated we authored the steps and decision points in starting an early psychosis program. So what was mentioned earlier around that pre-implementation conversation and discussion, because so much of this is about planning around infrastructure. And we focus on sustainability and building state-level infrastructure. So you can see we've had our fingers in all kinds of states at different varying levels of intensity. So some differences between EASA and other CSC models in the United States. There's a lot of attention to systemic infrastructure and financing. As was mentioned earlier, there's a problem with private insurance companies not reimbursing for a lot of the services that we offer in early psychosis. So right now we get to cover it, but we certainly don't want that to drop off if the federal funding goes away. There's an inclusion of bipolar spectrum and clinical high risk. There's a different level of manualization, level of intensity and crisis response, inclusion of peer support, nursing and occupational therapy, and the inclusion of multifamily psychoeducation. So we have some training recommendations that we emphasize. The importance of consistent and coordinated regional approaches. So one of the things that's happening, communities within the same states are adopting different program models, which may not be problematic in practice, but when it comes to consultation and training, it gets a little problematic as to what to train to and how to support the uniqueness. So while we want the uniqueness to emerge, we also want to be able to support it. So I do this because I feel like Ryan, Tamara, and I do a lot of this kind of flexing, stay flexible and adaptable and focus on the evidence-based practices that we know matter and seek feedback. So states and communities are implementing elements of multiple models. So there's kind of a mix going on. And so who's going to support that and how and what does that look like and what does that mean for outcomes and individuals' experience when systems are in that kind of flux and change. Implementation requires significant leadership and systemic change and different approaches based on rural and frontier areas. So there must be cultural adaptations. We have different cultures. In Oregon, culture meaning ethnicity, rural, frontier, socioeconomic, poverty, access, education levels. There is a lot of differences that these models need to be adapted to in order for them to really take hold at the community level so the communities own them and can be empowered by them. Number of rural and cultural adaptations. So there's smaller incidence rate, smaller community sizes, and some incredibly large distances require different strategies. So there are some communities that have 1,000 people. It might be 2 hours to get to their local community mental health care center or for the provider to drive out to the home. So that's a resource-rich experience. Language help-seeking patterns sometimes are different and we're learning about this as we go along. What are those differences and how do we adapt to those differences? There is incredibly important attention to key cultural in-group leaders in order to partner and have community messaging take hold. We also know a little bit that typically people will seek support from cultural in-group leaders, particularly on stigmatized experiences before going to a stranger. So we want to kind of keep that in mind. It's not universal, but we want to pay attention to that. So challenges, I mentioned private insurance challenges and skill development. So this is can be a pretty complex clinical implementation, takes a lot of effort, and sometimes that just takes time and practice and feedback. And there's turnover in community mental health clinics. So how do we kind of allow for that and also respond and keep the core service going and provide the best service for our young people and their families? So our accomplishments, we are serving about 450 young people at any one time in our state. We have a Young Adult Leadership Council that's a council of active participants or alumni from EASA programs that serve as an expert advisory and directive committee. They are self-governing. They are participating in research projects, providing training, technical support, as well as working on outreach to other young people on an individual by individual basis in Oregon, and they sit at the Center for Excellence with us. So they're part of our team. Again, nearing statewide implementation. It's becoming a sustained part of service delivery, which is very exciting. The fidelity review is collaborative, focused on evidence-based practices and our guidelines, but again, we really seek feedback, even from people, what was the fidelity process like for you? How can we improve this process so your work can shine and you can ask strategic questions of us so we can partner and keep growing this? And we have several counties in the state of Oregon that, because of the success of EASA, were able to access funding that our legislature opened up in order to open up transitional youth programs based on the EASA model, but they're serving a very wide range of presenting challenges and have very different levels of duration of treatment. So that's really wonderful. And that's EASA in a nutshell. Thank you.
We've got one more presentation, and then we'll do our panel. So I'm going to introduce Susan Gingrich from the Navigate program.
There, it turns right in. Buongiorno. I've really been enjoying Italy and practicing the little bit that I know, but if it gets beyond greeting and eating, it's a little limited. So I'm really happy to be here and to talk a little bit about Navigate and to be with our colleagues from the US and from abroad. So just wanted to let you know at the beginning that our website, navigateconsultants.org, it has all of our manuals online. So if you're interested in learning more about Navigate, learning about IRT, our Individual Resiliency Training approach, or our Family Education approach, or our Supported Employment and Education Specialist, the manuals are there and they're completely free and downloadable. Okay, just a brief history of Navigate. We started in 2009 when NIMH launched what we think of as the RAISE initiative. And there were two teams that developed first episode programs. One would be the program that Aruma talked about, which used to be called the RAISE Connection Program, and is now called On Track. And the other was called the Early Treatment Program, and that's now called Navigate. And that's what we are going to be presenting about now. And as you probably noticed, both of the names that we've chosen are not acronyms. So the letters don't stand for anything. On Track stands for staying on track with your life, right? And Navigate stands for navigating your way back to health and to the life you wanted. So just a little bit about the study design, because we were fortunate to have a controlled research study. So half of the people that we worked with during the research part, or the RAISE part, were Navigate sites, and the other half were community care or control sites. And there were 17 sites of each. So the specifics of the Navigate program that you might be interested in is that we're based on the stress vulnerability model, that we're very enthusiastic about recovery and resiliency, that we want the clients who enter our program to have a message of hope and optimism from the get-go. We use principles of illness management and also psychiatric rehabilitation. and we emphasize the shared decision-making model. I think you heard more about that from Aruma, where we really feel like decisions that are made are not the clinicians telling clients what to do. It's within the evidence base, it's a shared model. We want not only their input, but their action. And then finally, we're always thinking, oh, whoa, that's nice. We're always thinking about the important things about first episode clients and how it might be. Some are similar to persons who've had multiple episodes, but some are quite different when you're that age and you're at that stage of the illness. So the program itself has 5 interventions. And you'll see a lot of similarities between what EASA and what On Track described in terms of the interventions. We have medication management. We have a family program. We have supported employment and education. We have individual resiliency training, which we call IRT. And then we also often have separate case managers. And also we have a lot of teams now who have separate peer specialists. And I'm real excited that that's a development that's happening since the initial research. Our typical staffing is for a team of 25 to 30 would be 1 full-time team leader / family clinician. So the director of our teams also serves as the family clinician. We feel like that's a great way for them to keep their finger on the pulse of things that are going on with the clients, because they're also working with the families. And because they're the first line, that's who comes into the program, usually often brings their family. And so they get a chance to meet them when they're doing enrolling and screening. We also have a 0.2 time prescriber. And by prescriber, we mean psychiatrist, nurse practitioner, or a physician's assistant. We have a full-time individual resiliency specialist. We have a full-time supported employment and education specialist, and the optional positions are the half-time case manager and half-time peer specialist. And we have found case management is extremely important for the persons to become resilient and recover their life, as often they have housing needs, they have transportation needs, they have financial needs, and having case management available makes a lot of difference. And I wish we had the requisite map, because there are some great maps came up here. You can probably memorize the map of the United States just based on the first episode programs. But we are currently providing across the U.S. in, I'll have to do the counting right here, 1, 2, 3, 4, 5, 6, 7 times 2 is 14 states, some of whom have more than one team. For example, Michigan now has 5 teams. And then there are some teams like Montana, which is a very small team in a rural part of the country, or more frontier, where the cowboys go. What's not on this list is that Piper Meyer did training in Israel about how to launch first episode programs using the Navigate model. So we're excited to see how that cultural adaptation goes. Our training is 2.5 days of in-person on-site at where the team is located. And we feel like it's real important for everyone to start off on the same page, like pull people together at the very beginning, talk about what the whole team is about, what first episode is about, how they're going to be working together. And that also, how are they going to do their team meetings? We usually do a mock team meeting in our training. And also, the whole team hears about medication management, so that the whole team is supporting what are good prescribing practices. The whole team is supporting paying attention to side effects. The whole team is supporting the low dosage of medications. So then we separate into separate groups for the rest of the training for the different interventions that I described on the past page, for the prescriber, IRT, team leader and family clinician, and supported employment and education. Then we have a system of individualized consultation for a year, where each, for the psychosocial interventions, for the IRT, SEE, and team leader, we have twice a month for 6-month calls, and for the prescriber, we have monthly calls. And we have the team leaders, we try to get them to join all the calls because we, again, the finger on the pulse is we want them to know what each intervention is about so that they can be supporting that and the use of all the interventions. And on those calls, we try to celebrate client successes and family successes. And at the same time, it's important to review challenging cases. And we find we need to do a lot of ongoing training during those calls, because the 2.5 days is a great beginning, but it's what happens when you go back to the ranch that often is the most challenging things for our clients, for our clients and for our teams. So our dissemination efforts has, as we mentioned, the development of that website so that people, when they look online, they might find Navigate, just like they would find On Track and EASA. We want people to be able to find us with the least possible amount of effort. And that also what we would like is having more contact information available for each other. I know I've referred people to on-track programs. A client who is moving from Florida to New York to go back to college contacted Aruna and said, is there an on-track program that she could come to? So it's been really nice to have that kind of implementation effort. I would say some of the implementations lessons that we've learned is that it's almost based on what I was noticing from Aruma's slide, is the conversations you have before you even begin. It's talking about what's required to implement, what needs to be in place for like a readiness assessment. Reviewing the guidelines for enrollment. What are the clear diagnostic categories? Because we actually take non-affective psychotic disorder, schizophrenia, schizophreniform, and schizoaffective. And that it's great to use that term psychosis because I think it's less stigmatizing and also less, like stuck on the name of a diagnosis and more about an experience. But psychosis, for when some people are thinking about referring folks to our program and say, well, he had a psychosis because he took LSD. Can he come to your program? We said, yes, that was a psychosis, but it's not one that's related to schizophrenia, schizophreniform, or schizoaffective. Recommendations for hiring staff was important. I'll be curious from Aruma if you ever went to the training and they had the wrong people at the table. Yeah, I see that you did. Yeah. Is that sometimes teams don't know who should be in which position. You know, it's great to say there's a family director and a family clinician, but who are we looking for? We want, for example, we want licensed master's level clinicians in the director role, the family clinician role, and the IRT role, and a BA level for supported employment education. And unless that's super clear, you may end up with people who are almost lay people coming. Okay. Another lesson that we learned was having everyone have an overview, that we can't expect people to read things on their own. It don't happen. So having that overview at the beginning, we decided was really a key part of that. And also that medication management piece was that we found things worked a whole lot better when we had Dr. Robinson, who is in our audience today. Dr. Robinson came and did it in person, because the webinar was not as effective. And also the interaction that you get is much better in person. And since the medication is such an important issue on whether people get relief from the medication, whether or not what level of side effects they have, it makes the difference sometimes between someone having improvements in their symptoms or not. So we really want to affect that. The other thing we found out that was helpful was that at the end of each training day is to have a meeting with the leadership, especially with the team leaders, and say, here's what we saw as strengths in your team as we were training them, and here's where we saw some problem areas. And so that it's almost part of that, continuing to get to kind of inform yourself. Like, it's not enough to have the right people in the room. There does need to be the right people in the room, but they need to be showing us as we're doing the training that they have the kind of requisite skills. For example, if we were doing training one place and someone was referring to people as schizophrenics, not using person first language, and even with some help was not using person first language. And we're saying, well, our people aren't ready to work, they're too ill. We're using a lot of non-recovery language, a lot of the non-recovery attitudes were being revealed. So we thought that was real important to tell the leadership about that, and that needed to be something to be addressed. So some of our recommendations were to practice anything you want to see in the team performance. It's really helpful if you can role play it while you got them in front of you. So if you want people to have weekly team meetings where they're actually talking to each other about clients in a very productive, quick way, it's best to show them what you mean. If you want people to be, for IRT, teaching cognitive restructuring in a very positive, supportive way, you need to role play that right there and then. So we felt like those things are really important. If you want people to feel comfortable with the family, you need to role play that. Okay, so the other thing is having clear recommendations for screening and recruitment, and I believe that's what almost everyone has said. I would say for family education too, we've had to prepare our clinicians for the wide variety of families that they're going to see. I think very often we expect that families may be like the families we know, or like our family might be if there was to be schizophrenia developed. Many of the families we work with have a very different response. Some of them say, he's 18, I shouldn't even be involved in his treatment. Or some will be, he's 18, but he's a baby, I need to be there every step of the way. So you're going to see all kinds of family situations and economic levels. So it's important to be flexible and be prepared. I would say that practicing strategies for IRT, for the individual resiliency training, has been very important to practice that during the training, as I mentioned earlier, and also to get folks to start using stuff as soon as they get back. So maybe they're just starting to enroll clients and they say, oh, we can't do anything that we learned in IRT yet. Well, we try to get them to use it with existing clients. If there's somebody they're already working with, use an IRT module with them, see how that works. Role play with each other as team members, see how that works, because the longer the gap between the training and when they use the skills, the more kind of tenuous the connection gets. I would say with SEE, we're now describing more up front what are the similarities and differences between the individual placement and support model, the IPS model, and the difference, and with supported employment and education, because there's a lot of similarities, but there's some differences. The piece about that we have most sort of challenges with in SEE is the job development piece, where we encourage our support employment and education specialists to go out and talk to employers in the community. Find out what kind of jobs they have. Find out what they're looking for in employees. Not disclosing anything about the clients, but just becoming part of the community and knowing what's there. And our clinicians were very gun-shy of that. And so what we now do is our SEE specialists, as part of the training, she says, okay, right after lunch, we're going out. And they go to a mall and go to 5 different employers. First they watch Shirley do it, and then they do their own. So having more hands-on with that. And then with the prescriber piece is that piece about having the whole team be knowledgeable and on board with that. Okay. So our challenges, and I realize we just have a few minutes left, and that is we have distinct cultural differences and needs in different parts of the country. We are a melting pot, and we have all kinds of minorities and ethnicities and socioeconomic groups, so that we just have to be more, it's important to address the special needs of those populations. Even in our rural areas, there's a lot of lack of trust in mental health, to say, among other things. Nobody wants to see a car that comes from the government in front of their house. The smaller population size and expecting the small caseloads, some of the agencies who would call say, we want to launch a full team. And say, what's your population? 50,000, they said. So, okay. So we help to kind of help them expect how many people will they actually have. that will develop a first episode statistically, but then also how do you make still a coordinated care model, but for fewer people. And then the final one is long distances to travel. And I know European countries can also have those long distances. In Montana, their first client was 75 miles away. So they were going out to make home visits because the family didn't want to come or wasn't able to come. And that's a long way. It's 150 miles round trip. So that, and there's no public transportation out there unless you can hitch a ride with somebody, you're sunk. Another challenge is multi-generational poverty, is that what we were finding is that many of our clients did not have a model of someone going out and working. And so that they were not looking for a job or expecting to be in school even before schizophrenia developed. So it's like, how can we help people have a more optimistic outlook for themselves and the idea that they can work, they can go to school when that hasn't been inculcated because of years of kind of being up against a lot of challenges. In addition is the young person may receive different messages about recovery from the team versus what they hear from their family. And sometimes the family's looking to supplement family income, and that's perfectly understandable, but that means they're encouraging applying for disability, which we know is very hard to get off of once you get going. And our final challenge is working with different payers, is that there's different ways that services are paid for in the states. I've been like stunned. Some states, case management is not covered at all, right? And then there's some places they cover it up the wazoo, but they don't cover clinicians, licensed clinicians, or don't reimburse for it except a tiny bit. So it's all different in that way. Private payers often don't reimburse for many of the coordinated specialty care services. So you think, oh, geez, that's great, private insurance, and also with Obamacare, with the expansion of insurance coverage, young people are covered up to the age of 26 on their parents' insurance, and we thought, yahoo! Then we find out they are allowed 5 visits with the mental health, with the counselor for the whole year, and you say, good and bad, right? Finally, would be that many clients are still uninsured, and that paying for their services is really important for us to address that. And I would like to stop by saying thank you for coming to the program, but I'm very interested in what our panel discussants have to say, because you have so much more experience with this than we have, and we're just so eager. And I think, did you want to ask folks? Yes. And I also get to say arrivederci.
I was going to ask our panelists to come up and join us, and I'm going to hand a microphone. We've got Marie Nordentoft from Denmark, Max Birchwood from the UK, Don Addington from Canada, and Owen Kalaki from Australia. So they're going to give us a little bit of feedback on some of the similarities and differences from what we talked about. So thank you.
Okay, I'll start. First of all, I would like to congratulate you with the fast rollout of these teams in many states. And having done that, I will turn to saying I think that many of the teams are too small and too few. And I think you have only seen the tip of the iceberg. And when I think of the development we had in Denmark, first we had only 2 teams when it was a research project, but after it had been implemented all the time, we've been surprised that still new waiting lists occurred and new people, the demand still were growing. And I remember being asked, how many teams do you think we will need in the capital region? And I hesitated a little bit and I said, okay, 7. And then in the end, now we have 11, and it has recently ended with 12, and maybe it's not enough yet, and we hadn't got the fantasy to see that, but it is that when there's an attractive service, people will come. And they might have been reluctant to seek help before, but now they dare to do it. So that's the first thing I would say. And then I will ask if you are aware how important groups are. I think not all the programs had groups, and I think it's really an important part of it because people help each other so much. So I think, and then I was really impressed with the manuals and the training, and I think there you have the advantage of being a very large system, so that you can do this in a much more professional way than we have been able to. So, and then I think this with the non-billable activities is really a challenge, and I think you will need to work hard on that. We do not have insurance and billable things as you have. We have a much more gentle system with some things are being counted and appear in statistics, and some does not. You know, everything's funded, but then we are. If we do not have enough of those visits, for instance, then we are blamed, and we are sometimes also threatened that if you do not get more of these, you will we will cut something, cut some of your staff members. And it's also about having home visits where the patient's not there. Then it's invisible and it doesn't count. And I think we'll have to fight about that, because if we do not make home visits where the patient's not there, we lose the most vulnerable people. So I think that will be a constant fight. Yeah, thank you.
Well, first of all, congratulations. I mean, the efforts and the incredible amounts of thought that's gone into your program, your dissemination program, is absolutely fantastic. It's very interesting. Comparing to where we were in late 90s, early 2000s, there are a lot of differences, mainly because the funding structure is very different. And I kept saying I mustn't talk about the differences in funding, but a lot of it was driven by that. So I might as well say it. We have a bit like with you guys, we have a top-down thing, right? So there's not multiple payers, there's one. And what our main, some of our early lessons were to do with that. One of them, partly what you were saying, Maretta, is that, being able to scale this, you need to understand the need. And there was a lot of, our experience was a bit of guesswork about what the need is. And then Peter Jones and various other colleagues were it's all started to become very clear that, if you're working in multi-ethnic inner city Birmingham in the UK, where I started out, the rate of psychosis is 5 times what it is in rural Cornwall, which is a place where you were born, as I remember you telling me. There's a peninsula at the bottom, and it's very, very different. And yet the resources that went into those settings were exactly the same. And so that was one issue that we learned. And then Peter Jones and colleagues developed this tool based on, I think it's called SignMap, is that right? Where commissioners could say, now, okay, I work in North London here, what's the expected rate of psychosis? And I think that's really important to have a population context. And obviously this is starting, but if you're really going to make a big difference to a public health issue, you need to have that context. The second point, I suppose, is that we were very concerned to make sure that this investment didn't disappear into a black hole. Because the Brits are brilliant at that. They get extra money and then it disappears all over the place. So what I was involved in right at the very beginning is writing down what it is you should be buying with this money. You should be buying, and so I, very prescriptively, I got a lot of criticism for this, but it was really useful. We said the team should employ these people, they should do this, and in particular, the teams had to have very clear objectives. How did they know they're succeeding? That was really, really important. Not just numbers that they were treating. So that, for example, engagement, how many people should you be engaging within 1 year and 2 years? How long should you keep them for? and what treatments should you be delivering. And so in our case, there was a lot more emphasis on setting that architecture right at the very beginning, because we were really concerned, partly because when we started, we had a lot of enemies and people wanted it used in slightly different ways. So there was a lot of effort on making sure it was ring-fenced. Just a couple of other things. We had a national rollout program, sort of on a smaller scale, obviously, in the UK. And we had two really, they're not here, unfortunately, you know Joe Smith and David Shires. These are really two very strong, very charismatic people. And they had developed a network, they did a lot of training, and also firefighting. They did a lot of work with Departments of Health, the grown-ups in the Departments of Health and the government, and also at the local level, saying, you know, there's not enough money going here, and where's the money gone? And they were able to make sure that the money didn't disappear in some kind of permeable space down there. That was really, really important. And there was one other thing I was going to say. Finally, I think the other thing that we found very useful is to be clear about what's happening to the existing first episodes, and to design the service to make sure that you are filling the gaps in the current structure. So in our case, for example, we found two things. One is that the existing clients, young people, were not engaging in generic community services. So there was no point in us putting extra resources and structure into an existing community service, because it's throwing good money after bad. They just didn't engage. So we stopped outpatient appointments and all that sort of thing because the young people didn't go. So we had to do a different service to respond to a different, you know, the experience, the real experience of first episode psychosis. And I think that was right. That's why we had these standalone teams. And the other point was that very important to think about treatment delay in DUP, and to measure that, but particularly our experience in the second generation of our services is to ask the question, where are the big sources of delay? And so measuring DUP, but not just measuring it and then saying, what do I do with that? But measuring three things: help-seeking delay, how long did it take for someone to get into the specialist service, and once they got into your service, how long was it before they got to you and got into treatment? And when we did that in the UK, we found that the biggest source of delay was in the mental health service. And so we have these in the second generation of our work. We have waiting time standards, which are now 2 weeks. So that once someone hits a mental health service, it's 2 weeks before they get into an early intervention team. And that was really important. Anyway, so those are my thoughts.
Okay, thank you. It is very encouraging to see the rollout of the programs and the degree of central support. I'm from Canada, and in Canada, it's each state or province does things differently, and we don't have any consistent standards, and there's a variation between each province in how they tackle that. So the one that perhaps does it the most successfully has clear standards, and then that can be linked to fidelity scales, which is used in one state. You mentioned it in Oregon. I'm not sure if that's being applied to all the other ones that you.
We have some fidelity and performance expectations, and we have a lot of data to measure DUP and
Right.
all of that.
Yeah.
Only in New York. The other states, we have no control, and they're developing their own as they institute.
Right, and so the fidelity and the performance measures, things like DUP, but also some of the other simpler things to measure, like employment rates, they are contextually bound, and they're going to be different in different places, but they are meaningful in the same area repeatedly over time, and they can be adjusted for socio demographic features and local employment rates if you want to do that. The same applies in education, and that's one way of managing that issue so that it's not applied into arbitrary a way, so that a remote rural area with a naturally high unemployment rate doesn't get penalized. And then performance measures, fidelity, and a population-based approach that seems to be clearly there in Oregon, getting to 90%. And it's hard to know, it's just beginning when you look at the size of the population. One cautionary thing is around defining your target population. Very clearly, it's very nice to include bipolars, but that increases the numbers and then you need more teams. And so one of the challenges we've faced is that hasn't actually been addressed very clearly and explicitly linked to funding as well. And so there's a sort of a game where some implicitly agree that either first episode, clinical high risk are included or not included, and bipolars are included or not included. It affects your funding model, and you have to think about that. So those are my comments. Thank you.
I guess I would add to all of this also by just saying how I was looking at Bob Heinz, so I'm going to call it the measles map that he kind of showed the other day, and it is kind of amazing that the short period of time that there's been so much thing, and I have to congratulate you on being able to keep up with the training around that as well. I mean, we in the last couple of years have been having our own expansion of services, but we've only got 6 sites around the country, and I've seen the kind of work that's gone into the preparation of manuals and the LMS that goes with that, and the face-to-face stuff. So, kind of in awe of the incredible effort that must have been to do all of that. I guess the things that I was thinking of, because I don't want to go through the development of EPIC, which has been talked about a lot, and Pat's talked about some of the funding challenges that we've faced recently. But I did want to come back to the funding point about, whilst you're in this great period of expansion, it's sometimes hard to see what the challenges down the road might be. And quite often the challenges down the road are that there's a change in the political will or something like that, and the funding, which seemed like it was just kind of part of the furniture, isn't there anymore. And it's thinking about, well, what do we have to do as we go along this journey of expansion and development in order to be able to be making the argument so that day is very difficult to bring about. And not that this is about the early psychosis stuff, but one of the things in Australia with our Headspace, which is our primary mental health care thing, we have in our federal parliament 150 politicians, there's 150 electorates. And what we've tried to be pushing the line is that every politician should have at least one Headspace clinic in their electorate, because then it becomes an issue on a very local level for them. And you have, 438 odd Congress people. If that's the ultimate aim, the selling point to them is what a great legacy to have in their, I don't know whether they're called districts or whatever they are. But then that becomes something to defend against this being taken away as well. The other thing that I think that we've worked really hard on doing is the involvement of family and young people, both in the design of the services, the thinking about what we're offering, how we're offering that, in the research that we do in those things, but also as partners in our advocacy as well, because there's a certain amount of thing that, if we say, do you know what we need is we need more money and funding for mental health, and people are going to go, well, you would say that, wouldn't you? Because that's a very self-interested argument. It's a lot harder to ignore that argument when it's coming from a young person who's got a very compelling story to tell about what would have happened to their life had they not had access to this service. And it's fascinating. We've recently made this video to do, like everybody else, we're trying to get money. So, we've been working with trying to get some philanthropists. We made this video with some young people, and during the course of this taping, one of our young people told this story we didn't know. She's an identical twin. And so she talked about her absolute unique insight into what it meant to have had spent 5 years chasing help for her mental health, whilst her twin sister didn't have to do that. And she talked about the fact that they've ended up in very different socioeconomic strata, very different opportunities, very different things that they've been able to achieve. And, and it's kind of like this completely sliding door thing, and that's a much more powerful thing than me coming and saying, well, check out this evidence, So it's to think about these things forward so that this isn't just this wonderful growth period, but it's the beginning of something amazing and sustainable. And I think I'll stop there.
One of the two people I mentioned earlier who led the rollout, David Shires, he's a carer and was a GP, and his daughter developed psychosis, and he was a fantastically powerful voice. And he did not have that perception that he's kind of biased because wants to fund his program. He came in to a completely different, and it is very powerful to have that user and consumer voice right at your side, because I couldn't agree more. You're going to hit turbulence. What's the initial euphoria of doing it? Then you'll hit the turbulence, and then you'll need all the help you get from as many grown-ups as you can, as many consumers as you can. But you're absolutely right. Yeah, good point. Thank you.
I think it might be noted parenthetically, just with all of the enthusiasm. I was just saying it might be noted parenthetically with all of the enthusiasm that the additional set-aside money is spent almost entirely on hiring a few different additional staff, not on actually providing training. So the vast majority of the places implementing these programs don't have full training programs in any one of the models. And please correct me if I'm wrong, among the trainers out there. And so what it has done is given an impetus to developing first episode teams, a shared focus and enthusiasm for that. But probably I don't think we would say that the teams are kind of fully functional, and so the money in some ways is spread very thin, and so in addition to issues in terms of ensuring and increasing funding, because of course you could never get this much funding to cover all of the first episode psychosis services needed across the country, there's a need to think in terms of how to economically build in quality training into those services so that they can most effectively meet the need. Or that would be a comment that I have.
Actually, it's true. In our case, listening to your, the quality of the training that you provide is very, very high. Comparing and contrasting, in the early days, we were fixated on making sure the money got there, that the teams were in operation, and there's a badge on the door that said early intervention. And there was training, but nothing on the scale that you're describing, and probably not, there was subsequently, but perhaps not the same quality. I suppose what did happen was that it attracted a certain kind of individual, and that's really interesting. When you do, it attracts people who are naturally committed and who want to deliver care in a different way, in a different philosophy. That's fascinating. I know Robin Murray. He led a commission called Schizophrenia Commission a few years ago in England, looking at the current state of mental health care. And he kept on getting loads of people coming forward and saying, these early intervention services, they're fantastic. And it always to the point where he got sick of hearing about it. And he said the main thing that he noted about it was that the workers and the staff in it, the staff and the users had a passion that wasn't seen elsewhere. Everyone was trodden down by whatever, and that's probably quite important to have those kind of stuff and keep morale up and keep people, when they use the word evangelical, you know what I mean?
No, I think evangelicals, right?
Is that right?
No, I do. I completely agree. those kind of, there's sort of the managerial imperatives that come down from, I don't know, the health bureaucrats. In the early days, what you'd have is these, the team managers now fighting back upwards because that's what they did. They said, well, that's not how we're going to do this because we're this kind of service. But it's kind of changed. There's a little less fight backwards now. And part of that has been, part of that has led to there's been funding cuts in that, and that kind of becomes its own vicious circle. But if you can have, essentially passionate agitators who believe in what we're doing, and it's interesting, I've said this to Pat before too, that, and you might remember better, but it seems to me that in the sort of late 80s and early 90s when all of this was developing, the people who were developing it, you were the radical outsiders in mental health. You were there's a line in poetry somewhere that says, if you want to serve your age, betray it. And that's exactly what you did. You betrayed the consensus on how mental health should be done. And it's important that we continue to do that.
Yeah, thank you. The way this discussion is kind of going along, I think, a very interesting direction, and it was suggested by your comment. What I was about to ask about something else when we get to that. But the issue of accountability for funding when there comes a bit of a surge or maybe an expansion, and how to make sure that's done in an accountable way. We're in Maine, Portland, Maine, which is just beginning meaning a year and a half ago, started a team under the Now is the Time Healthy Transition Initiative from SAMHSA, and as well as the Mental Health Block Grant. We have no idea where all that money has gone. We know that on the Now is the Time project, our first episode team accounted for about a quarter of the funding that came to the state. Our sense is probably the rest was sprinkled around to various other vested interests or 10% of somebody's salary who was supposedly working on the project. We never saw them. But it just soaked into the bureaucracy like water into the sand. And I mean, very concretely, just this week before coming here, we were debating, and we don't have an answer on this, whether to insist, we've politely asked, but to insist, citing the Federal Freedom of Information Act, that we want to see the budget, and we want to see where it's going. And now the mental health block grant has gone up, there's more money sloshing around, but then also, who are we talking with? We're talking to people who do not come to meetings like this. And it's sort of a bit of an us and them thing between the professionals where we all think we know what we're talking about and what the evidence says about where this energy and resources should go, and people who are very highly suspicious of us, that we're basically feathering our own nest and we're supporting our own departments and we're whatever. Of course, now one important way around that, as you suggested, is to get families and patients, and it's just wonderful when we get a legislator, which we have a few of, and we try to cultivate this, who has a son with, bipolar disorder or schizophrenia or committed suicide and, that kind of thing. But there's not, it's a huge problem, and how to make these arguments in a way that, where we maintain a relationship with the people we want to work with and don't get into a completely adversarial battle and try to lead, but kind of almost like leading from behind, leading without being too obnoxious about it. I'm just curious how all of you have dealt with this. I'm sure you face it in many different forms.
I haven't dealt with it in terms of in Massachusetts. The money has gone to existing first episode psychosis programs that don't actually meet the criteria for coordinated specialty care clinics, much to my annoyance.
Yeah, one of the things that we've done, and I'm working to push even harder to be more conservative around, is in our fidelity guidelines, there are network agreements. And in order to use the name EASA, the leadership must abide by the network agreements. And we are explicit about what that means, which involves allocating of resources, time, consultation to training, protecting their staff, and the funding to do so. And if somebody fails a fidelity review for any reason, infrastructure or leadership, then they've got a very limited amount of time where they're going to come back and just tell us exactly what the action planning is. I'm going to go out soon and do collaborative action planning. They can rely on our support center to say, okay, you've come up with barriers, maybe you can't problem solve them. We'll help you problem solve them, but there's a time-limited, very specific expectation. And that if that actually, I think in one instance, when community was not able to meet it at all despite efforts, and the funding was taken away and then given to another community that wanted to serve their population. And so we've had to embed that, and I am pushing in the next update of the fidelity guidelines to make it more explicit, more concrete, in order to respond somewhat to that. So it's one possible solution.
And I would say that what we've done is, in Minnesota in particular, is we've done a lot of education at our state DHS level about what are the models, what does this mean, what are other states doing, how important it is to spend this money responsibly, because we had a significant delay in Minnesota for them to actually decide what they were actually going to do, and the clock was starting to run out. And so it was a constant kind of providing this education and contact, and I think that we continue to need to do more so that we don't know what's going to happen with this set aside and how long it's going to last, and I think this is where we can play a role in our state governments to continue to try to support this. We have one more question.
Yeah, just slightly different area. I'm wondering how long you expect people to be able to be in one of these programs, and what's the plan for continuity of care after that? I work in New York City and the area both inpatient and outpatient. I just know how frustrating it can be to make referrals for someone with schizophrenia. We've been able to use the on-track programs, which is really great, and I'm just wondering if there's some vision about how to keep the services going.
I think that for us, what we're doing is we say that people can be in the program for an average of 2 years, but some people do stay in the program longer, up to 3 years, I think has been the upper limit. And I know that part of what we're discussing is this idea of, well, the idea is that as you're doing the outreach and the networking, you're also identifying as a provider who are some good referral sources that you can use on the back end as you're trying to do a discharge. But we've also noticed that there has been issues with discharge planning, so our attention is turning towards, are we going to develop step-down programs? And is it going to be a widespread state thing as we're doing with On Track, or is it going to be individual clinics that want to take this on and figure out? We've had some just feedback from certain centers that have said, well, why don't we develop something? And we might just help support that. I know that from a funding perspective, there isn't anything there right now set to develop that, but it's definitely, discharge is now what's on our radar because of the idea of how do people do, what are the outcomes. We gather a lot of data, but we don't have a lot of follow-up after people get discharged. So, yeah.
So transition planning and our fidelity guidelines, first of all, from the outset, the education that this is a transitional program in nature, the way the team does weekly clinical meetings, communication, treatment goal setting, all of that is in place to look towards transition. And then we have very clear markers that we look for in fidelity reviews of 8 months out that you're starting with a transition plan. We have a checklist with all the recommended areas to focus that must be individualized. 8 months, 6 months, 3 months, with all the key stakeholders on board and agreeing and actually signing the plan in many cases to focus on that. When I first started on a clinical team, there was no healthcare reform. Many young people were covered, so they would drop off. It was devastating for years, devastating. Now that we've got healthcare reform and more integrated services rolling out for youth in general, it seems to be solving some of the problem. But even if there isn't somewhere to go, you're still it's beholden to the team to look at what are the natural resources and how is this need gonna be met, and tracking it on a timeline.
And I would say that we're still in the early stages of figuring that out, as many of our teams are extremely new. So we've been very busy with training. So I think that what we are in the process of still trying to figure that out. But I would say we're in the same boat in recommending 2 to 3 years as a minimum to keep people. And I think what we're going to find is, what do the services look like when they start to transition? And that's going to be the bigger question.
Navigate model is that the teams are embedded within a larger mental health center, and especially the prescribers are doing other things. So one of the things that we've been trying to encourage the teams is, even when the person, quote unquote, leaves the specialty care, that they keep at least the same prescriber, because the prescriber is working in a general clinic. Because at least to have some continuity, at least one person of their treating, who's treating them, stay with them, makes a huge difference. Because when you, not only when you change programs, but when you change personnel that the person, that the client's been used to, that makes it, there's a huge drop off. So we have some of that advantage, at least keeping somebody to help them.
Tell me if I'm off base. We're thinking that we would say step down means you go to or transition, you go into a relapse prevention mode and a continuity mode where we're available as consultants, and we're worried we'll get swamped. For every time somebody has a bad weekend, we'll get called. But nevertheless, that we would be available by phone or for a one-shot, in person-to-person or telemedicine contact, but that we wouldn't completely go away. Because we're just concerned about, and there's unfortunately good data to say when the services stop, people go down the tubes very quickly in some cases. And anyway, yeah.
This will be our last one, Kim.
I think that it's interesting. We know from ACT teams that, and ACT teams are primarily relapse prevention, rehospitalization prevention, oriented. And we know you can successfully transition people from ACT teams down to less intensive teams using strategies along the lines of what you're describing, kind of semi like permeable boundaries, gradual handoff, and things like that. I think to me, the bigger consideration is looking to have some kind of continuity in the psychosocial programming. For example, supported employment and education, or supported employment was always defined as being time unlimited. Many people go down over time in terms of the services and intensity that they need. Psychosocial programming around areas like social cognition, social skills training, things like that may need to continue. And to the extent that those are available outside of a specialty team, then I think it's good. I would think in terms of a little bit less about the need for relapse prevention, crisis management, and a little bit more in terms of the needs for some kind of ongoing psychosocial programming to help people continue to improve the quality of their lives.
Can I ask a question? I'm not quite clear how this set-aside works. Is what you call it?
Yeah.
Okay.
Mental health block grant.
Okay, mental health block grant. So do people have to come forward and kind of bid for it?
Nope.
They don't. Okay. Well, just one.
They have to submit a plan.
They have to submit a plan.
Right, but every state gets a certain amount based on their mental health funding. So it's
Right.
guaranteed if they submit a plan, then they get this set amount.
Okay.
Based on their population.
Well,
Right.
just one thought. I don't know if this, if this is a model that's set in stone, but I've been working with some colleagues in Wales, next door, and they've it's a quasi-autonomous area, and they're developing early programs, and they've done, there's been a national allocation of resources. And what I suggested they do is that when people come forward and say, we'd like to do this, they have to come forward with a plan, but including some matched funding on the basis that you guys are already seeing psychosis. How are you going to use the resources you already used to add to this to build a better service? And they only got the money on that basis. But I don't know. Yeah, that's
That's a really good point. Well, thank you. This has been so wonderful. I really appreciate all of our panelists and our speakers, and this has been really, really great. So thank you all for coming and staying a little bit late.